Good morning, ladies and gentlemen. Today's lecture is on a very important topic, that is, the ulcers in the oral cavity. I am Professor Ashar Ahmed Mashood, and if you are hearing my lecture, please subscribe to my channel. Thank you very much. There are several causes of ulcers in the mouth. If the ulcer has developed as a single episode, you must consider the local factors such as trauma, of a dental appliance, a sharp tooth, or irradiation. It can be because of some infection, drugs like nicotinil, or Steven Johnson syndrome or TEN. If the ulcers are recurrent, then the first and the foremost cause is aphthous ulcers and recurrent erythema multiforme. For persistent oral ulcers, you must consider the causes like immunobullous disorders, pemphigus or pemphigoid, oral lichen planus, lupus erythematosus, Bechet syndrome or Bechet disease, several vasculitides, and ulcerative colitis or Crohn's disease. While single persistent ulcer is mainly due to some cancer or malignant neoplasm. The general management of an oral ulcer would be to maintain a good oral hygiene, use of hot saline mouth washes or baths, 0.2% aqueous chlorhexidine gluconate mouthwash, 0.15% benzidamine mouthwash, occasionally mechanical protection with plastic guard. But any patient with a single ulcer that lasts more than 2 to 3 weeks should be regarded suspicious and may need a biopsy. The traumatic ulcerative granulomas, also known as the eosinophilic ulcer. This is a benign self-limiting lesion that typically affect the tongue. It is rare and may easily be mistaken for cancer or microbial infection. It affects older adults like 50 to 80 with slight female predominance. Trauma is found to be the contributing factor, and that's why the name also includes trauma. Pathological features show extensive subepithelial inflammatory cell infiltrate with predominant eosinophils and histological similarity to CD30 positive lymphoproliferative disorders. The peripheral blood eosinophil count is, however, normal. The clinical features typically affect the lateral or dorsal surface of the tongue, and it presents as rapidly developing solitary ulcer with elevated or indurated margins, varying in size from few millimeters to several centimeters. In addition, submucosal masses, multifocal lesions, and recurrence is also described. Diagnostic biopsy is must, and management is conservative excisional biopsy if the ulcer is a small one, or intralesional and topical corticosteroids. The recurrent aphthous stomatitis, which is one of the main disease that need to be considered in this section. The recurrent aphthous stomatitis is characterized by multiple recurrent round or ovoid ulcers, which have a circumscribed margins, erythematous halo, and yellow or gray base. So an aphthous ulcer has these typical features: a circumscribed margin, erythematous halo, and yellow or gray base. Lesions may be single or multiple, and there are three main subtypes. Aphthous usually lasts 1 to 6 weeks, depending upon the subtype, before healing spontaneously. So if we don't give any treatment, even then they are bound to heal spontaneously. and recurrence is very typical in all type of aphthous ulcers. The natural history of recurrent aphthous stomatitis is that of eventual remission, but may take many years and is bothersome for many individuals. Pathophysiology. It is quite a common disease and the prevalence is 10 to 20% in the general population. It typically starts in childhood or adolescence with slight female predominance and it is often familial. The familial nature is proved by the increased frequency of HLA, A2, A11, B12, and DR2 among the patients suffering from recurrent aphthous stomatitis. There is no known association with systemic autoimmune disorders. Immune dysregulation leads to exaggerated pro-inflammatory process or a relatively weak anti-inflammatory response. Environmental factors. Stress is one of the very important factors contributing to recurrent aphthous stomatitis. Then trauma from biting the mucosa or from dental appliance. Cessation of smoking may precipitate or exacerbate recurrent aphthous stomatitis, which is interestingly the only disease which is not common in smokers. Deficiencies of iron, folic acid, and vitamin B is found, so there is some rationale in giving the multivitamins as a treatment. In women, recurrent aphthous stomatitis is related to fall in progesterone levels in the luteal phase of the menstrual cycle. So they develop in the mid-cycle. The clinical features. Patients with recurrent aphthous stomatitis have no clinically detectable systemic symptoms or sign. And the main three clinical types are the minor aphthous ulcers, which contribute to more than 80% of recurrent aphthous stomatitis, major aphthous ulcers, and herpetiform ulcers. Now, a few words about the minor aphthous ulcers. Typically occur from 10 to 40 years of age. Ulcers are small, round, or ovoid, 2 to 4 millimeter in diameter, and occur in crops of only a few ulcers, 1 to 6. They affect mainly the non-keratinized, mobile mucosa of the lip, cheek, floor of mouth, sulci or ventrum of the tongue, and occasionally soft palate or fauces. Ulcer heal in 7 to 10 days and recur at an interval of 1 to 4 months. They heal without scarring. Major aphthous ulcers. They are large, frequently about 1 centimeter in diameter, found on any area of oral mucosa, including the keratinized dorsum surface of the tongue and palate. Also occur in crop, but only few ulcers at a time and heal slowly and take about 10 to 40 days. They are very painful, although the minor aphthous are also painful, but the major aphthous are very painful and they heal with scarring, while minor aphthous don't heal with scarring. Then herpetiform ulcers. This type is found in slightly older age group and begins with a vesicle which passes rapidly into multiple 10 to 100 minute pinhead-sized discrete ulcers that increase in size and coalesce to leave large round ragged ulcers. They involve oral site but mainly on the tongue. Healing takes 10 days or longer. They are extremely painful and recur so frequently that ulcers can be labeled as virtually continuous. They have a lot of similarities clinically with herpes simplex, but despite of all efforts, herpes simplex virus is never found in such patients. Then aphthous-like ulcers. They include conditions such as immunodeficiencies as HIV and cyclic neutropenia. the Bechet's disease, malabsorption states like celiac disease or Crohn's disease, the autoinflammatory conditions such as periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis, Sweet syndrome, and drugs, especially NSAID and nicodrenal. Nicorandil. Investigations. The diagnosis of recurrent aphthous stomatitis is based on history and clinical features with no specific test available. Biopsy is indicated only when some other cause of ulcer is suspected. To exclude number of systemic disorders, undertake following investigations like blood complete picture, red cell folate assay, serum ferritin and B12, calcium measurement, which is low in celiac disease, and tissue transglutaminase or IgA anti-endomysial antibody assay to rule out the celiac disease. Management. Trauma. Patient should avoid hard and sharp foods. Any iron or vitamin deficiency should be corrected. Good oral hygiene is to be maintained with chlorhexidine mouthwashes. Anti-inflammatory agents like benzidamine may help in reducing the discomfort. The topical analgesic sprays like lidocaine gel or spray may be used to reduce the discomfort. Topical corticosteroids are the mainstay of the treatment. Amide potency hydrocortisone hemisuccinate pellets, named as the Corlin, or triamcinolone acetonide in carboxymethyl cellulose paste, that is Canalog and Ora base, is the most commonly used treatment. Usually, these ointments or gels are short in our country, so you can use these soluble beta-methasone tablets, betnisol, 0.5 mg, dissolved in 10 ml of water, and use as a mouthwash. Have to prescribe 2 to 3 times. Don't have to ingest it, but just use as a mouthwash. Large or recalcitrant ulcers are treated by intralesional triamcinolone injection, like we do in oral lichen planus or pemphigus. Then topical tetracycline, a capsule of 100 mg doxycycline dissolved in 10 ml of water, also used as a mouth rinse, may provide relief and reduce ulcer duration due to its anti-inflammatory effect. Then short course of corticosteroids may be prescribed. And if nothing is successful, then immunomodulators like colchicine, azathioprine, pentoxifylline, cyclosporin, dapsone, interferon, or anti-tumor necrotic factor alpha agents. Complex aphthous. This term is a term which is used to apply to patients with either more than 3 almost continual oral aphthous or recurrent oral and genital aphthous, but no other feature of Bechet's disease. It's important in these cases to undertake a full screening for underlying systemic cause, secondary complex aphthousis, especially for underlying inflammatory bowel disease. The majority, however, will be idiopathic. These patients are usually well controlled with colchicine and beta-methasone mouthwash or azathioprine. Combined colchicine and dapsone may also be used. Now, the last and the most important cause of recurrent aphthous ulcers in oral cavity and genital is the adenomatous Bechet's disease. Adenomatous Bechet's disease, also known as the Bechet's disease, is a systemic vasculitis of unknown etiology involving all types and size of blood vessels. It is characterized clinically by recurrent courses of oral aphthous ulcers, the genital ulcers, skin lesions which can be papillopustules or erythema nodosum, and iridocyclitis or posterior uveitis. It is occasionally accompanied by arthritis and vascular, neurological, gastrointestinal, and other manifestations. The ABD most often affect patients in 20s and 30s, so disease of young adults, and both genders are equally affected. Pathogenesis. There is an association with HLA-B51, and such patients have severe disease. It's an immune-mediated occlusive vasculitis. The pathology reaction is induced by rapid accumulation of neutrophils and later by T lymphocytes and macrophages. A predominant Th1 immune response induced by interleukin 12 is the cause of pathology. The possibility that infection may stimulate an abnormal immune response, for example, Th1 anti-streptococcal activity. Histopathology, there are three main types of histopathological reaction in Bechet disease. The first one is the vasculitis or vasculopathy. There is a lymphocytic or granulomatous vasculitis with or without thrombosis of blood vessels, necrosis, or fibrinoid deposition. Then there is an extravascular infiltration of mononuclear cells or neutrophil predominant inflammatory infiltrate in the dermis or the panicles. Then the third is the suppurative or mixed granulomatous folliculitis. So vasculitis or vasculopathy, perivascular inflammatory infiltrate with lymphocytes and neutrophils, then suppurative or mixed granulomatous folliculitis. This picture shows lymphocytic vasculitis. Their vessels is involved, is surrounded by lymphocytes without thrombosis. And here you can see the neutrophil predominant infiltrate in the dermis. So Bechet disease also comes in the diagnosis of neutrophilic dermatosis. Subcorneal neutrophilic pustule is seen. This is an ulcer with other non-specific mixed inflammatory infiltrate. The criteria of international study group for diagnosis of Bechet disease. The major criteria is always the recurrent oral ulcers. Can be minor aphthous, major aphthous, or herpetiform ulcers, which have a recurrence of 3 times in one 12-month period. So 3-time recurrence in 1 year is the major criteria of Bechet disease. Plus, there has to be 2 more criteria among the following 4 lesions. Recurrent genital ulcers or eye lesion. Eye lesion can be anterior uveitis, posterior uveitis, cell in the vitreous on slit lamp examination, or retinal vasculitis. Skin lesions can be erythema nodosum, pseudofolliculitis or papillopustular lesions, acneiform nodules as observed by physicians. Then the last is the positive pathology reaction, which is read after 24 to 48 hours. There is a revised international criteria of Bechet disease, giving 2 points to oral lesions, recurrent, 2 points to oral aphthous, 2 points to genital aphthous, 1 point to recurrent skin lesions, 1 point to CNS lesions, and 1 point to vascular manifestation. Pathology is not included in the criteria. So if we add up the points and the score is more than 4, then we label it as Bechet disease. Though main scoring does not include pathology test, but pathology testing is conducted, a positive result may be included for 1 extra point. The clinical features. Oral ulcers is a defining criteria and therefore is present in 100% of the patients, and spontaneously healing of aphthous occur in 4 days to 1 month. Genital ulcers present in almost 90% of the subjects. They may not recur as often as oral ulcers, and usually heal with scar. Among the skin lesions, the pustular vasculitis is seen 55 to 83%, and erythema nodosum in 44 to 62%. And any of these two would be sufficient for the diagnostic criteria. The pathology is triggered by significant inflammatory response by minor injuries such as venipuncture and occur in about 40% of the individuals. These are the multiple superficial aphthous ulcers, and this is the anterior and posterior uveitis and genital ulcers. The systemic lesions. Eye, uveitis, posterior or panuveitis is the main ocular feature. Other vascular involvement include affecting the arteries and veins, leading to aneurysm and occlusions that can sometimes be fatal. Other sites of venous thrombosis include the vena cava, hepatic veins, the Budd-Chiari syndrome, and cerebral venous sinuses. Neurological complaints including parenchymal and dural sinus thrombosis, meningoencephalitis seen in 3% of the patient. Peripheral neuropathies are rare. Joint may be affected with asymmetrical, migratory, non-erosive oligoarthritis in 30 to 40%. The GI involvement is uncommon and consists of mucosal ulceration, which is obvious, and these ulcerations is seen in ileum and colon as well, mimicking the inflammatory bowel disease. Something about the pathology test. A positive pathology test manifests within 48 hours as an erythematous papule more than 2 millimeter or a pustule at the site of skin needle prick or after intracutaneous injection of zero point 0.1 ml of isotonic saline using a 20 gauge needle without prior disinfection of the injection site. So you don't have to disinfect the injection site and either inject a 0.1 ml isotonic saline with an insulin syringe or just do a needle prick. The skin prick is generally placed at an angle of 45 degree, 3 to 5 millimeter deep, intracutaneous on volar foramen. Erythema without a papule is considered negative. Treatment of oral aphthous ulcers in patient of Bechet's disease. General treatment measurements include mild diet and avoidance of hard, spicy, and salty nutrients, irritating chemicals such as nuts, oranges, lemon, tomatoes, spices, alcohol, mouthwashes, and toothpastes. The topical treatments include the caustic solutions are silver nitrate applied with a cotton bud over the ulcers once or twice a day, or antiseptic and anti-inflammatory preparations like triclosan 0.1%, chlorhexidine 1 to 2%, benzodiazepine, or tetracycline. Corticosteroids, triamcinolone mucosal cream, ointment or paste, or intrafocal injection of triamcinolone, 5 to 10 milligram per ml. Cyclosporin 500 mg solution as a mouthwash TDS. Sucralfate suspension 1 gram in 5 ml QID for oral aphthous and genital ulcers. The treatment ladder for mucocutaneous lesions. So lesions are seen in the skin as well as mucosae. Topical first line is antimicrobial agent, sucralfate or corticosteroid. Systemic include colchicine or colchicine plus benzathine penicillin. Second line include the anti-inflammatory agents topically and lexanox. Systemic treatment include corticosteroids, dapsone, azathioprine, and thalidomide. The third line include topical anesthetic cream and silver nitrate, and systemic include zinc sulfate, ribamapidine, ribamapide, pentoxifylline, methotrexate, cyclosporin A, interferon alpha, and anti-tumor necrotic factor alpha agents. Since the effectiveness of topical agents is generally limited to the application area, it should always be combined with a systemic therapy. So, whether we are doing a first line, second line, or third line treatment, the topical agents must always be combined with a systemic agent. For an ocular disease, the first line is the topical corticosteroids, midratics, and cycloplegic agents. And systemic include corticosteroids, cyclosporin, and azathioprine. The second line include interferon alpha and anti-tumor necrotic factor alpha agents. Third line includes cyclophosphamide and methotrexate. Topical agents as a sole agent should be restricted to patients with mild uveitis or anterior uveitis. Then treatment ladder for articular, gastrointestinal, and vascular involvement in Behçet's disease. First line is colchicine plus benzathine penicillin or anti-inflammatory analgesics. Second line is azathioprine and corticosteroids. Third line is methotrexate, celizopirin, interferon alpha, and anti-tumor necrotic factor alpha agents. Treatment ladder for CNS involvement. First line is corticosteroids. Second line is azathioprine, cyclophosphamide, and anti-tumor necrotic factor alpha agents. Third line is methotrexate and anticoagulants. Summary of treatment of systemic complications. All the systemic manifestation of Behçet's disease is treated with systemic corticosteroids. For severe ocular, neurological, or vascular disease, immunosuppressives like azathioprine, methotrexate, and cyclosporin is used. Cyclosporin should be used with caution due to neurotoxicity. Increasingly, the anti-tumor necrotic factor alpha agents like infliximab or etanercept have been documented to be effective, especially in uveitis, although dapsone is more effective inhibitor of pathologic response than etanercept. Thank you very much for your patient listening, and hopefully see you next time with another edition of my talk. Goodbye and have a good day.